We have a great turnout. We're already up to 40 people, and I'm sure that more will roll in. Today, we are very fortunate to have Dr. Andrew Krahn with us, courtesy of Dr. Nora Goldschlager's nomination. So thank you, Dr. Krahn, for joining. He will be talking about latent and genetic causes of cardiac arrest and sudden death. A little bit about Dr. Krahn. He is the professor of medicine at the University of British Columbia, where he's the chair of heart rhythm disorders. He is the immediate past president of HRS. He has published over 400 papers in peer-reviewed journals and sits on the editorial boards of Heart Rhythm and several other journals. His expertise lies in management of cardiac arrhythmias, and his research interests include the investigation of genetic causes of arrhythmias, sudden cardiac arrest, syncope, and implantable arrhythmia devices. His work includes leading a cohort of, cardiac arrest survivors with preserved ejection fraction in the CASPR registry, which I think he'll be talking about today. So thank you, Dr. Krahn, for joining, and I'll let you take it from here.
Well, thank you very much, James. Maybe I'll look at James and just ask, just to verify. James, thumbs up if you can hear me clearly. Good. Okay. Okay. So I've had an interest in this for a very long time, and some of the EPs will know some of the people who I originally trained with in London, Ontario, Raymond Yee and George Klein. And so I'll start with a story, and that is, I was in clinic as an EP fellow, and my boss said to me, go to the stress lab and supervise exercise tests. And I said, oh, that's an unusual task. What am I doing? And they said, well, there's two brothers who have long QT. And I said, well, what am I looking for? And the answer was arrhythmia. And so I went down and I met two boys named Trevor and Derek. They were brothers. Their grandmother died suddenly shortly after giving birth to their mother. Their mother had had a cardiac arrest at one point and had a pacemaker. And they had their EKG showed clear evidence of QT prolongation. And that really piqued my interest because it was pretty clear we didn't know what we were looking for. In terms of what was good, what was bad, the QTs were long. It varied a lot with exercise and recovery. And so what do I make of all of this? And that piqued my interest. And this was long before there was access to genetic testing. So that was early 90s, so that's 30 years ago. And ironically, although my background is blurred, in fact, Derek's EKG hangs on the wall behind me because it was kind of an inception moment for a big research interest of mine. So what you're going to see is some case discussion, some registry formation, some outcomes of some of these unusual events. For people who aren't in EP, we are going to talk a bit about things like imaging and latent structural explanations for cardiac arrest and sort of the merits of broad genetic testing and so on. So it won't be, it's a bit of a niche area, but I'm hoping that it'll still bear some interest for a broad audience. So, okay, nothing to declare. So I'm going to start with a mea culpa case. So this is about 8 years ago, maybe 7 years ago. I'm in the clinic and we're seeing families for these cardiogenetic conditions. We have a clinic every week. And while we are in clinic, there's a disturbance in the force. There's a disruption in the front office because somebody has come into the reception area and is sort of shouting and very upset and getting a lot of attention. And it is a young mom. And Donna was, I would say at the time, was in her early 40s. No, a little older than that, late 40s. And she is here with her big, looks like an offensive lineman son. And she says, my daughter died 2 days ago. I am in the place that can apparently make sure my son doesn't die too. So this was extraordinary that she found our clinic and stomped in with her son and said, I'm not leaving until you check my son. So this was by far and away the fastest sort of track for evaluating a sudden death. So her daughter was watching a movie in a room, and when her mom went to check on her about 2 hours later when her mom had actually awakened in the night and had a bad feeling. She went to check on her daughter, and her daughter was unresponsive and couldn't be resuscitated. So, and then you can see from the pedigree, so that's bottom right is the person who's crossed out, and then the brother is next to her, and then there's Donna, the mom. So we promptly put her son through diagnostic testing, and this was something that we saw during treadmill testing. So he's on the treadmill, and he has this complex ventricular ectopy. And we say, aha, maybe this is CPVT. It's a little odd that his sister wouldn't have had some kind of symptoms beforehand, but it happens. And now what do we do? So we put him on Nadolol, and we did genetic testing on retained DNA from his sister's retained materials at autopsy. She did not have any variants relative to the gene that causes CPVT. She had a variant of unknown significance in a gene that is the most common form of long QT, type 1 long QT. And so we thought, well, that doesn't quite fit. So we did a full genetic panel on her brother Devin, and found nothing. We repeated his treadmill on Nadolol, and the complex ectopy turned into a couple PVCs. And we discussed an ICD with him, offering it, also with his mother present, and he declined. He didn't want one. He said, I'm happy on the pills, and I'll leave it at that. And trust me, we discussed an ICD with him at every encounter. So I'm sorry for the quality of this ECG, but this is Mom's ECG. And Mom had a complete phenotype, which included Holter, stress, echo, signal averaged ECG, resting ECG, high lead ECG, and got nothing. And 2 years later, she died in her sleep. So this is a very humbling and compelling situation where the young woman who died in her sleep began the story. Her brother, who has a phenotype, has no genetic evidence to support it. Her mother, who carried the same variant as her daughter did, died in her sleep with a normal phenotype. She'd been thoroughly phenotyped. We've gone on to do whole exome sequencing on all three of these research DNA samples and not found any new variants. And it turns out that her mother's father died at age 31, which we found out quite a bit later. It took some time to get at this bit of information because it was kind of a family secret. So these are the kind of humbling situations that really motivate a person like me to say that we understand so little. We need to work so hard to try to understand the combination between the environment, the clinical phenotype, and the genetic information to understand the causes of sudden death, and in principle, either get ahead of them or develop better therapies to prevent them from happening. So a little bit of terminology. So let's start with the idea of either a cardiac arrest or sudden death. Of course, the difference is resuscitation. So if you're not resuscitated, you're deceased on the left. And if you are, you're a cardiac arrest survivor. And then you go on then to have an autopsy if you're deceased, and it can find a mechanism for death that's genetic or not. Or the clinical evaluation similarly can find a mechanism for a phenotype that's genetic or not. And then genetic testing targets that and then informs the evaluation of family members. And the first line assessment in this situation for the patients who are fortunate enough to be resuscitated are the things that are done almost by the time we get involved, which is an ECG, a cath, usually, and an echocardiogram. And then what I'll advocate for is this idea of further testing. This at the time was felt to be kind of new when we began this whole journey of doing comprehensive systematic testing, including provocation. But things like a CMR, exercise test, or if they can't exercise, an epinephrine challenge, and then a sodium channel blocker. These are the sort of standard tests that are done in these cardiac arrest survivors to look for an etiology. And although I won't focus on it, 90% of patients will have an overt cause of cardiac arrest if they're resuscitated, dominated by coronary disease about 60% of the time, and some form of structural disease without coronary disease about 30% of the time. And at the bottom here, then what you end up happening if all this testing is negative, you have either an unexplained death or sudden arrhythmic death syndrome, or an unexplained cardiac arrest, or what we call unexplained cardiac, or UCA. Personally, and if you look through the guidelines recommendations around terminology, there's some ambiguity about terminology, and we've tried to make a statement about this, but I prefer the term unexplained cardiac arrest instead of idiopathic VF, in part because the VF isn't always recorded. If you go through resuscitation records, it's not always carefully elucidated. And as you know, ICD interrogations in patients who've had sudden death have actually shown that VF is not anything but maybe the very final thing in many apparent cardiac arrests. So part of my interest began, and this is the first good paper on this topic, where we tried to systematically approach these unexplained cardiac arrest patients with a battery of tests. And what was new at the time was the idea of doing epinephrine challenges and procainamide infusions. This was around the era where epinephrine as a provocation factor for long QT was coming out. It was also then recognized as the CPVT genetics became evident. And sodium channel blockers, procainamides are only one in North America, and this is the drug that, it's obviously used to provoke evidence of Brugada. So in the end, I like to think of this in terms of the sort of buckets of things of what we do. And we start off with ECGs and then imaging. What was more novel, but is now universal, or should be, is an MRI at present before a device goes in, because despite the fact we have MRI compatible devices, cardiac MRI in patients with implantable compatible devices are often very difficult to interpret or impossible. It's just too much artifact. And a CT or PET, depending on whether there's sort of phenotype-driven suspicion about a cause that's best elucidated with one of those tests. Provocative testing is what EP does, right? We like to make trouble. And so one thing that's often forgotten is an exercise test because they've had a cath. And so people think, well, why would you do an exercise test? And the answer is to provoke electrical abnormalities, either an actual arrhythmia, especially in patients with exercise-related events, or evidence of QT maladaptation, because exercise test is useful in about 90% of genetic long QT. And then a sodium channel blocker to look for evidence along with high leads for Brugada. And then genetic testing historically has been used when there is a phenotype suspected. So you provoke findings that look like CPVT, like the patient Ed mentioned with a exertional swimming related cardiac arrest. And then you look for those related things. I'm going to show you some more systematic genetic testing and show you that that can be incrementally valuable. So my rationale as a person who likes to get people together and assemble things is that rare diseases need collaboration and cooperation to try to create sufficient mass that we can actually detect patterns and understand diseases better. So this started off with after the original observation around 2001 with me approaching 3 friends that were relatively nearby. And then so it went from 1 site, which was my idea and our local patients, to 4 sites, to 8 sites, to 13 sites, to 17 sites, to 20 sites, to now 24 sites. And so this is a map of Canada, and this is our what's called Hearts in Rhythm, our hero organization. And this is in a way reflects for the most part the population density in Canada. So we have 24 cardiogenetics clinics in Canada. This includes 4 pediatric sites. These are all enrolling sites in a national registry that's funded by our version of the NIH called CIHR. And so this is our dashboard from our registry database. And although the screenshot's actually a little bit dated, this tells you a little bit about who's in this. So, I think for James's interest, because he was talking about CASPR are the unexplained cardiac arrest patients and their families. And the most recent of this, I'll show you data on 699 patients. But we also enroll patients with these other conditions with long-standing interest in long QT and ARVC, and growing interest to expand this into Brugada, which we're working on now, and then CPVT as well. So just a reminder before we move on to some other things that are a bit more novel is, remember, provoke the abnormality and do a treadmill test. Don't forget about the cardiac MRI, and make sure the MRI is being interpreted by somebody who you really trust to look for these latent conditions. and then the provocation with drugs. These are things that are incremental, that are often forgotten because in our pragmatic hospital system, patients have a cardiac arrest, and the faster you get the ICD in and get them out, the better. But the reality is some of these tests, particularly the cardiac MRI, needs to be done before there's hardware in there, in part to make sure that you obtain a good quality image. Okay, I see a couple things in the chat, so maybe I should see what's going on there. Did mom get an autopsy? That's a very good question. She did indeed, and it was negative.
Including toxicology?
Including toxicology. Yeah. And yeah, the tragedy of that case reverberates in my head, and I don't have some magic answer for you, but I can say that I'm committed to continuing to work at this. Okay, so genetic testing. This is a good question. So, there are a bunch of case series that are mostly retrospective case series looking at the combination of unexplained cardiac arrest and the utility of genetic testing. And the real premise of this is either a broad cardiac panel like people would be doing now, or one that's focused more on arrhythmia or focused on structural heart disease. And so if you look at all these case series over the last 10 years, I'll try to summarize what some of that shows. But basically what it shows, and what was in the original guidelines, is don't do it systematically, but you could consider it, particularly if it's driven by a phenotype. And so what's new in this area is we've gone from an original paper where we said that patients who had either a family history or who had pre-arrest symptoms or had a borderline phenotype were well suited to genetic testing, to now our latest of this is looking at whole exome sequencing in 228 of these patients. And I'll show you a bit about what that shows. And the good news is we're just actually going through and curating the results on another, so we'll have about 500 of these cardiac arrest patients where we'll have more comprehensive genetic evaluation that's not driven by phenotype suspicion. So let's start here on these 228 cases. So these are unselected, apparently unexplained cardiac arrest. So this is after they undergo diagnostic testing and they're still unexplained. So if you look at the patients who had whole exome sequencing, so this is all the expressed cardiac genes. So the yield is about 10%. Okay. And if you say, well, that's a low yield, it is, but it's new information, particularly in a patient or a family where the event is relatively unexplained. And those are reasonably evenly split between electrical or ion channel genes and cardiomyopathy genes. And remember, these are cardiomyopathy genes in patients who don't have a cardiomyopathy phenotype. There's a couple of these where, for example, I remember one of these cases where the patient had a history of hypertension. They were on 3 antihypertensive agents, had a history that was suggestive of poorly controlled hypertension, and had a bit of concentric LVH, but that was it, and had a clear-cut evidence of an HCM pathogenic variant. So then if you take a diagnosis after phenotypic assessment in the post-arrest, so you start off with about 10% of people who undergo this more provocative and advanced imaging approach. And then you look at those patients who have genetic testing. 8% of those patients had a positive yield, 6% if you only take patients who had all 3 of the main provocation tests, CMR, sodium channel blocker, and an exercise test. And then if you go on to that after genetic screening, then you add genetic screening to the phenotype assessment and you get 17%. So we're starting to chip away at making a diagnosis. Again, the concealed cardiomyopathy is a very intriguing observation that requires further follow-up to see whether they'll develop more evidence of the myopathic component to this. And then if you just follow to look for an emerging phenotype, then you get up to 20%. So this is the basic merits of genetic testing, which appears to be incrementally valuable to a thorough phenotyping approach. And again, I'll talk a little bit about some of the emerging diagnoses that are coming out and how that then adds to this equation of what you're looking for, and also how to counsel patients as they go through both evaluation and then follow-up. So this has been informative because the new guidelines, which are a partnership between the different global specialty heart rhythm societies, the guidelines led by Arthur Wilde from Amsterdam said that genetic testing may be considered. So it's like a 2A indication in North American speak. And so this changes the needle a little bit for the idea of a permissive approach to genetic testing, assuming that it's done within the context of genetic expertise and typically a multidisciplinary team if possible. So, Ed, do you have an EP fellow, or maybe we can even put James on the on this spot and say, have you seen this kind of initiation of VF before? Very quiet. Okay. I suppose I might argue, can you still hear me?
I can hear you. I think the fellows are looking. Okay. Our EP fellows are probably working.
Okay. Yeah. Okay. So, you know, about, it's probably a little more than 10 years ago, Sammy Viskin came to visit us and showed a tracing of a case like this and said, if you see this, you'll never forget it. It wasn't this case, it was a different one, but and this is a beautiful example where we coincidentally happened to record the onset of a cardiac arrest. And the key thing in this situation is it was a young, healthy woman with a previous cardiac arrest with no positive testing whatsoever, no ambient PVCs, no cardiomyopathy of any sort. And then this happens, and she came in with both ICD shocks and pre-syncope. And this is a good example of it. And the key thing with this onset is, in part, the very short coupling of the initiating PVC. And most of these patients also have a very stereotypic, it's the same morphology of PVCs in general that tend to originate from the His-Purkinje system. And in a way, that's the only way you can have it so short coupled, is it has to come from the His-Purkinje system. And the reason this is relevant is because there are usual resuscitation measures to try to make this kind of thing go away that are autonomically slowing effects like beta blockers and amiodarone and so on. In fact, don't help or make it worse. And it's exquisitely sensitive to isoproterenol and quinine. So this is short-coupled VF or short-coupled idiopathic ventricular fibrillation. We've proposed, and it seems to be adopted, to take the idiopathic out, because by now we have at least a description for it, even though we don't necessarily have a clear mechanism. So we looked at this across our network and looked at how often this happens, because you have to catch the recurrence, not the incident event, to be able to detect what's going on, and look at it in the spectrum of unexplained cardiac arrest. And so if you look at these patients who started with unexplained cardiac arrest, and then ultimately either on the left, short-coupled VF happened, or on the right, other Casper etiologies, like emerging evidence of structural heart disease or things like CPVT and so on, the coupling interval of the initiating PVC is completely different. So, and if you look on the right-hand panel here, you look at what that coupling interval. So these are very short coupled on the upslope of the T wave most of the time, or right at the apex of the T wave. And there's a little bit of evidence I'll show you that there are some people who think that we shouldn't be too restrictive about this. But because 95% of the onsets were less than 340 milliseconds, we proposed that short-coupled VF should be a cutoff less than 350 for the initiating PVC. So 7% of these unexplained cardiac arrest survivors in the cohort where we were able to assemble this, who had more than a year of follow-up, met diagnostic criteria for short-coupled VF. And 80% of those, of course, it had to involve more than the incident hospitalization where they might have had recurrence, and it had to involve either ICD or monitored recurrence. And again, very short coupling interval. And these patients in general do not have a family history. We did actually whole exome sequencing on them and didn't find any variants of that were explanatory. And the average time from their incident arrest to recurrence was actually 2.5 years. Next thing is when you look at their probability of recurrence, the probability is basically drives the diagnoses out of unexplained cardiac arrest into an alternate diagnosis. So Sammy Viskin is of the opinion that everyone with unexplained cardiac arrest is short-coupled VF waiting to happen. I can discuss that, but I think the answer is it's not nearly that simple, but many of them are. And this is useful to know because it influences things like your shock plan when you're managing this in your device clinic. And then the other aspect of it is that quinidine is it's typically uniquely sensitive to quinidine, which is difficult to access and toxic. But in low doses, it appears to at times be very effective. So the Dutch then turned around and looked at this, and some people who are very much into this neck of the woods also know there's a founder variant in the gene called DPP6 that causes sudden death in young and middle-aged individuals in the Netherlands that looks a lot like this. In fact, it replicates the phenotype, but DPP6 has not been found as a culprit outside of a founder variant from the northeast part of the Netherlands. And so they looked at this. And again, the same, if you look at the graphic here, this is the summary, and then the same kind of onset, short coupled. They found a minority of patients, 10% of patients, their coupling interval was longer, or they had short and long coupled events. And about half of their cases were patients with this DPP6 variant, and the other half were, if you like our cases. And so as a result, you remember I said 6 to 7% of unexplained cardiac arrest are short coupled VF. Well, they got 8%. 8% were short coupled, and an additional 8% were DPP6 related short coupling. So it fits with their population being enriched, but that the overall risk is in the order of about just under 10%. So if you find this interesting, I think the EPs will take a definite interest in this. Is that the question is, does this etiology, EP has always talked about this idea of a trigger and substrate. And so with the PVCs being so short coupled, it's logical that they would have their origin in the His-Purkinje system. And then the question is whether there's actually an anatomic component to it that's part of that substrate aspect of it. So this is a very nice review that's in press right now in Heart Rhythm that walks through targeting His-Purkinje tissue in these patients who have these rare ventricular fibrillation syndromes by Michel Hasseger. And like early Repol and Brugada and short coupled VF, each of these has a unique approach anatomically and is potentially well suited to ablation. Unlike Brugada, where it's more of an arrhythmogenic substrate, where there's an epicardial anatomic substrate, these conditions tend to have very quiescent disease where they don't have ambient PVCs. So targeting triggers is difficult. And so as a result, I think unproven is the idea of going after the His-Purkinje system in an anatomic format. And so typically, if you're going to consider ablation, you need to do it while they're hot. So if they come in with a shock, then consider taking them to the lab in the first couple days, simply because that's when you'll be able to find the abnormal combination of trigger and substrate. So welcome comments from people, because I know people like Ed Gerstenfield live for this type of stuff. And then if you're interested in this topic, this is just a very nice review from last year by Bernard de Bellehussen, who also has a very big interest in this and is assembling an international cohort called Thesis that looks at this population across a number of centers. So just to show that we can still learn something, here's something that's very rare. So this is a paper from 5 years ago by now that looks at something called familial ST depression syndrome. And these are patients who have structurally normal hearts that can at times have LV dysfunction, but not necessarily. And they have this persistent, bizarre-looking repolarization with ST depression. We've looked in our own registry, and in fact, we found one case that was unrecognized and felt to be an atypical repolarization until we reviewed all the ECGs. And the genetic mechanism for this is unknown, but this clearly appears to be a Mendelian familial condition. And surprisingly, we've not been able, even with trios and whole genome sequencing, to find an explanation. So for the people who aren't in EP now, you can finally wake up and pay attention, because something interesting might be about to happen. And that is what I would consider to be the latest candidate in this whole area of unexplained cardiac arrest, is the whole question about the mitral valve. So, for many years, mitral valve prolapse was felt to be a relatively benign finding. And then over time, it became evident there was a malignant variant, among other things, either because they developed progressive structural abnormalities, or more likely there was a strong arrhythmic component to it. And then the question about mitral annular disjunction and MVP, and then the connection to malignant arrhythmias and cardiac arrest. So this is a very nice summary of this coming from the Netherlands group again. And they took 72 patients with apparent idiopathic VF, 72 matched control from their own registry, and looked at their CMRs. And so the interesting thing, if you look on the bottom figure down here, is that MVP was present in 11%, 8% of them, disjunction was present in 11%, 8% had MVP, and they are often but not always overlapped. So you can have disjunction without MVP, MVP without disjunction. But in controls, obviously, this is much less common. And so as a result, the question is whether the MVP that's typically dismissed as a bystander, is that it may be a significant, if not etiology, then potentially at least a contributor. So we looked at this in our own population, and 6% of our patients had evidence of MVP, and we looked at a matched population that was 2.4%. And about 80% of those, MVP was their only finding on phenotype evaluation. And of course, these are patients who did not have moderate to severe mitral regurg with severe MVP out of the gate. So these are patients who at inception probably had some degree of MVP, and it in fact required an imaging review to detect that this was considered to be of potential clinical relevance. And so the findings that drove whether there was risk, we proposed something that's a score. It's actually in press now, should be out shortly in JACC-EP. But things like bileaflet prolapse, disjunction, complex ectopy, and a family history were the drivers that seemed to be associated with a greater risk in this situation. So finally, I want to just take a little bit of time and walk you through some data I got this morning, because this is a project that we're working on to look at our cohort of unexplained cardiac arrest patients and their outcomes. So this is just under 700 patients, and the mean follow-up here is 7.8 years. So it's a pretty large cohort, that's been 20 years in the assembly. And if we robustly go through their diagnostic information, it's a bit complicated in terms of how strong the diagnosis is, but we have a whole mechanism published, grid for how these are classified. But what you can tell patients that at least in intermediate term follow-up, 2/3 of the patients will remain unexplained. So that's 65%. And you can see here the spectrum of the diagnoses that show up. So short coupled VF is in fact the most prevalent diagnostic outcome. Early repolarization next in line, and mitral valve prolapse third in line. And these categories of what I call the IVF syndromes, the channelopathy syndromes, if you like, the inherited cardiomyopathy syndromes, and then the structural abnormalities, which include things like unrecognized myocarditis, infarction, embolism, spasm, and so on, that aren't detected by the initial evaluation. And in another format, this is the pie diagram version in terms of people who like to see it that way. Okay, now I see questions as I opened up the chat. So maybe we'll just defer that because I am kind of on the home stretch. And if you look at it as a pie diagram, you can say this. So these are the things that we are looking for as we either complete a thorough evaluation at baseline, which includes genetic testing, in my opinion, or as we follow the phenotype. And it may be different in your environment, but I know in ours, if you take a patient who had a cardiac arrest that's unexplained, they often have very little phenotyping over time. When's the last time that they had A, B, or C? And we even had somebody referred recently who had a cardiac arrest in a smaller city, was referred in because finally somebody sort of clicked that maybe we should do some further testing. And they had not had an EKG in 5 years. And so I find it remarkable you can have an ICD check and not have an ECG. And so this is helpful for counseling patients, because the other part of it is, when you look at this, is how much of this is inherited, right? And the answer is very much the minorities. You can tell most patients that your family's not at risk. And it's a separate talk to talk about our work that's been done by us and others about family evaluations, but the yield of family evaluations is low. And that fits from the fact that the proband explanation is not typically Mendelian genetic. Okay, so this is just a reminder in terms of what's actually happening out there. And this paper is 5 years old. I was a reviewer on the paper, and it is in a different health system. So there's a Paris resuscitation consortium, and they look at the outcome of cardiac arrests and so on. And part of this was to say, well, how often are we actually doing a guideline recommended, diagnostic evaluation of patients after cardiac arrest, particularly when they did initial exclusion of patients who had overt cardiomyopathy or coronary disease. And in Paris, and you can argue, well, the French would rather be on strike than do diagnostic testing. But in Paris, at least, really, almost, 1 out of 8 people had, proper cardiac evaluation and consideration of genetic testing. So, only 18% of individuals actually underwent genetic testing of any kind. So, this argues that although our idealistic or regional referral center approach is relatively systematic and thorough, the majority of patients can go through this process, not find an explanation, and not really have thorough diagnostic testing or repeat phenotyping during follow-up to look for diagnosis. So I think we have a lot of work to do to sort of get to the point where we're really forensically trying to get to the bottom of these cases, and then the impact of this has on their families. So I'll end up with something that's part joke but part real. So a couple of weeks ago we had our HRX meeting in Seattle, which is an innovation meeting by the Heart Rhythm Society, and there was a stream that talked about AI and machine learning and generative AI and ChatGPT and so on. And as I'm sitting, listening and learning about this and so on, I thought, well, perhaps what I should do is I should ask them, what should I do with the title of this talk? What should I talk about? And then this is the 15 steps that ChatGPT generated, followed by the recommendation that after all relevant information is gathered, healthcare professionals can work together to determine the underlying cause of the apparently unexplained cardiac arrest. Treatment and management plans can then be tailored to address the specific diagnosis and reduce the risk of future cardiac events. So it turns out these rounds have actually been presented by the digital twins avatar of Andrew Krahn. And Andrew is in clinic right now, taking care of patients, doing this until the avatar can take over care and he can go golfing. So tongue in cheek, but it is interesting that if you've been reading this slide while I've been talking, it's remarkably good. Some of which is because I think we've written good things into our guidelines about the evaluation and role of genetic testing, but also because of its ability to assemble, the global information in this area and make it this good at providing guidance. So the take-home message is, review the arrest record and all the ECGs. They'll show some things that are quite fascinating if you dig deeply. Provoke with exercise and pharmacologic approaches, and don't forget to do an MRI before you put an ICD in. Do genetic testing, and my only coaching advice is to make sure that someone within the team or a regional partner that has genetic expertise. There's the odd Mike Ackerman in this world, but most of us, in fact, require some degree of partnership with aspects of pathology, imaging, genetics, clinical phenotype evaluation to really piece all the components together. And follow the patient, because that will give you clues. Keep looking for a phenotype to emerge and make a plan, because some of the etiologies either have important therapeutic decisions for how you program devices, what medical therapy you use, or have important family implications if you detect structural causes, for instance, that aren't genetic. And above all, stay curious, which is one of the things that makes our field so much fun. So to conclude, these are just some important websites of some materials that you have. Our national network is an open access network. So our HERO network, we have a whole care toolkit We give away the materials that are necessary just to function as a cardiogenetic clinic, family letters and communications, case summaries, those kinds of things. So please, by all means, reach out if you have any questions. And for now, what I'm going to do is I'm going to open up the chat and answer any questions as you see fit. James, do you want me to start with questions? You want to ask the audience, or how do you want to proceed?
Yeah, well, first off, thanks for the great talk, your commitment to this, very mysterious entity in some ways, and your focus on phenotype is definitely appreciated. From my work with Zion and his autopsy cohort. I guess naturally, one of my biggest curiosities remains about the 65 unexplained. What do you think is the path to trying to unlock that mystery there? Serial testing, yeah.
So, I mean, I think that's a very good question. I've been thinking about this a lot. When you think about the buckets or the bins, so you could see something along the lines like this. So you start off with an unexplained cardiac arrest, and then there's a proportion of those patients that are probably one and done. And though the one and dones, it may be there's some unrecognized etiology. And so a good example is, do we really have a good way to detect subtle evidence of inflammation that somehow in a vulnerable person creates that isn't going to recur? Or one of the things we've learned from device interrogations is that not all of these are cardiac arrest in the traditional VF defibrillation kind of approach. But some people will be one and done. And so, in fact, one of the things we're now on this outcome project that we're working on, we've got some patients who had their arrest 15 years ago and nothing's happened, not even non-sustained VT on their device. So there's a one and done population. So then the second population are patients where they have some electrical phenotype. And as you know, in EP, this sort of eclectic paroxysmal nature of some rhythm conditions means that it'll take years for it to unmask. And so a good example with short coupled VF is I had a lady who arrested at the age of 50 with squeaky clean phenotype, and almost 10 years to the day later, she developed short coupled VF that was documented by her device and got 2 appropriate shocks. I have no good explanation for that. How she can live to 50 without it and then have 10 years apart between the 2 episodes and no evidence of an intercurrent change. And we did everything again. We recathed her, re-imaged her, everything. So anyway, so there'll be electrical abnormalities that will take time. And unfortunately, in many of those electrical abnormalities, genetic testing will not be a smoking gun. So the third population, I think, are patients where we're just getting smarter at recognizing that they have clinical or genetic evidence of an underlying structural abnormality, but we haven't yet got, or we're not conclusive in our initial phenotyping to know for sure that's what it is. And so a good example is, they have, it's a young woman with MVP with, 6 millimeters of disjunction and some PVCs, but it's not a smoking gun. And over time, if she then develops progressive regurg, LV dilatation, complex ectopy, and then eventually gets either, a surgical indication or an arrest, then it's pretty clear. And so part of this is just learning that we should have ascribed it to the MVP at the beginning. The interesting group, though, is if you go back to the genetic information is, we all harbor about 6 genetic variants that should make us sick or dead that don't. And so the downside with the idea of just broadly genetic testing everybody is the idea that we're going to find this. So what does this mean? Kind of thing. And we're in no position to really answer that question until basically everyone is in an electronic health record constantly being monitored and reported. So in this situation, the question is, what is the arrhythmogenic dose of a cardiomyopathy scenario without a mechanical correlate mean? So, the way I've been, sorry to rant, but the way I have been thinking about this of late is that every form of cardiomyopathy is an arrhythmogenic cardiomyopathy. It's just that the dose of arrhythmia versus myopathy is variable across the spectrum of things and even sometimes within families. So, this morning in clinic, because I'm in cardiogenics clinic today. This morning in clinic, I saw a number of patients where what's happened, the floodgates have opened for somebody who has an EF of 40 and complex ventricular ectopy and they're under age 60. As long as it's not ischemic, they're coming in for genetic testing. And quite frankly, recent papers suggest the yield of genetic testing in that situation is 10 to 20%. So, we're really looking at, whether you can arrest with HCM without hypertrophy. And the unanswered question is 10 or 20 years later, we would develop hypertrophy. So I know that's a long answer, but I think those are the buckets that I think about in terms of how we see this unfolding over time.
Thanks. And if I might just sneak in maybe a more straightforward question. How many of the patients, the UCA population got toxicology?
Yeah, it's a good question. Probably very much the minority of them. Most of the forensic pathology and coronial system includes toxicology as part of the definition of foul play, because coroner systems are driven typically, actually not by health, but by legal. And so toxicology is usually done. And if you saw some recent nice Danish work saying that toxicology is a significant, at least factor, if not driver, in a minority of autopsy patients. But in arrest patients, not very common, but it's a good question.
All right. Well, I think I can open it up to the audience. If I think we have a couple questions in the chat. Dr. Goldschlager, do you want to ask yours?
Yeah, thank you, Andrew. This was really magnificent. I have a question. Since I don't understand ERS, early repolarization syndrome, I'm not sure what to get from the literature. I don't know where we are with that. But my question is, can you, and if you do, why, see something like short coupled in other syndromes, such as ERS? Or go ahead.
Yeah, it's a really good question. So, so there's this Venn diagram of sort of clustered overlap of Brugada, short coupled VF, early repolarization, that in a way falls under this bucket of J-wave syndromes. It's a bit of a descriptor group. They also tend to have relatively short QT intervals. And that kind of fits with the idea of a hyperactive His-Purkinje system. So the short answer is, most Brugada patients, their onsets are short coupled. So, the culprit PVC is coming from the His-Purkinje system. And this is part of that platform that Michel Asseguer has been advocating around the idea that you can trigger map around the His-Purkinje system to try to find these moderator bands or false tendons or those aspects of things that may be the structural origin, that you can then reduce the burden or the trigger for the events. So yeah, for sure.
Thank you.
Dr. Sang, you have your hand raised.
Andrew Zian here. Thank you for your work. Great presentation. First thing I wanted to mention was, as James pointed out, overdose and toxicology positive is a much bigger problem than you think. In that Danish study you quoted was 57% of autopsy cases had positive toxicology. It's actually more than half. So I bet if you look carefully at that UCA population and you do systematic toxicology, much more will come up, because that could be partially the answer as to why 10 years later, for example.
Yeah, the one and done.
Exactly. And then, I'll echo your, deep phenotyping of these survivors, which is so important. But what's missing in the non-survivors on the left side of that diagram, the deceased, as you point out in the coronial system, rarely do those get autopsied. And that's kind of the population we're looking at carefully here. The people that would never come to your clinic or mine or Ed's as survivors, because they died out of the hospital. So, what does that population look like? And so hopefully we'll be able to shine some light on that part.
Yeah, I think, practically speaking, in genetics, there's this concept of extreme phenotype, where essentially what happens is, the most severe cases of whatever's going on show up first, that are drawn to attention. And we have this idea that long QT is this generally dangerous and fatal thing, and it's really mostly a very benign thing, as you understand its impact across the entire population. So I think in this situation, if you look at our sudden death, if you look at the general population, what we're talking about is a trivial, tiny little wedge of what's going on. But our hope is, of course, that we're learning something that's more generalizable. I think the reality in the population that you're looking at in the autopsy series, for example, is it's typically multifactorial, because you can give a little bit too much antidepressant or THC or alcohol poisoning to a lot of people and they don't die suddenly. So it's a contributor, but it's not quite as simple as black and white. And I think that's the case for most of our events. I mean, the mystery that we're unraveling right now in medicine, the greatest question in medicine in my mind is the temporal aspect, because the combination of the temporal aspect and environmental factors are the things that were basically unmeasured in most conditions. Why now is the big question. And in the arrhythmia business, it's pretty unforgiving, but the reality is, why do coronaries, arthritis, asthma, etc., why are they flare-up paroxysmal diseases, which many of our diseases are? So it's a little tangential, but I think the question about toxicology is primary versus secondary factor, and then how to interpret the toxicology models of the agents, the scope of the extent of overdose, and so on. So it's a very, very valid point.
No, absolutely. I think my last comment on there would be the majority of cases it was a contributor, but there are a significant proportion, I'd say a third of them, were frankly toxic, frankly overdose. That was the reason why they died, not a contributor. But definitely there's a proportion there where it alone wouldn't have killed them, but it could have been the reason for that day.
Yeah, I mean, this is one of the sobering things I heard a reminder about recently, was that during the COVID epidemic, many more people in Vancouver and BC died of overdose than died of COVID, which just sat in the background while the fentanyl went in and the Narcan didn't get there in time. It's tragic and very real.
Right. Dr. Delling, I know you have to go, so maybe you'll go next.
Yes, hi, great talk. I have a couple of questions about the mitral prolapse phenotype. I follow a number of these patients in my clinic. I was just curious to see what you think about those that don't have annular disjunction, and also if you've noted some case reports about concomitant long QT in these patients, and what do you make of that?
Yeah, very good question. This is an area of confusion for me. We're working on trying to get some core lab content in this to try to see if we can find something smarter between the echo and the MRIs. I think the reality is that so the foundation is MVP is common, it's usually benign. There's relatively few of these patients who really have much in terms of manifest or provocable arrhythmia. And there's also a structural element to it with progressive regurgitation and dilatation, and then the merits of intervention. There's a whole literature now on intervention in this situation to try to mitigate this, including ablations or surgical ablation at the same time. The disjunction part of it makes sense that the disjunction contributes to, if you like, the mechanical generation of ventricular ectopy and so on, because you can see that in other mechanical conditions where that appears to be the case. And so the problem right now is in fact a small hypothesis generating observation on our part is this idea of overlap. Some have disjunction without much prolapse, other way around. The question that's not overt is many of these patients seem to be happening before they have overt, at least moderate regurg or LV dilatation, and their heart function's intact. So, that speaks to the arrhythmogenic dose coming first, a bit like ARVC. So I think in general, what's easy is, when they have overt florid MVP with mitral regurg, where you get worried about them when they have a complex phenotype, and then the question about, device versus valve-based interventions. The overlap with long QT, I have to say, is anecdotal. Long QT is 1 in 2,000. Borderline QT is 1 in 100. We'll have a borderline upper limit of normal kind of QT. So not quite sure what that means, if it's bad luck for those people, but I don't understand a plausible biologic direct connection. Not sure if that answers your question, but I think we got a lot of work to do to look at more prospective registries around MVP to understand it better.
Yes, I meant like long QT genes rather than just the long QT, actual genetic findings. Yeah.
Yeah. I think the challenge in this situation is very nice paper from Scandinavia. I think it was from maybe Finland, where they took a population of patients with ARVC and looked at the yield of genetic testing, and they looked at the strength of the diagnosis of the ARVC. And then because of their, solitary managed health system, they also then tested controls. And depending on how you interpret the genetic testing, 1 to 4% of controls had what should have been a genetic explanation for ARVC, even though they were just healthy volunteers. So the background noise to genetic testing makes things really complicated. And if we start doing it on a very broad scale, the challenge will be the old epidemiology of most of what you find will be false positives.
Thank you.
Dr. Gerstenfeld?
Yeah, I think we're wrapping up. I guess I just have one comment, maybe a plug for humanity, which I think in your ChatGPT slide, it omitted a stress test. So maybe we still have a role in finding those patients. But thanks. It was a great talk, Andrew. Really appreciate it.
Oh, here it is. Number 11, provocative test like exercise tests.
Okay. Oh, well, I didn't see that.
Okay. Well, better to be a has-been than a never was, right? At least we thought of it to get it into ChatGPT.
All in there. All in there. Thanks, Andrew.
Okay.
I think on that note, that's a delightful note to end. Dr. Krahn, thank you again for your time and fantastic talk.
Okay, and thanks for having me.